Welcome to the EMS Documentation Workshop by Cornerstone Admin Systems. My name is Travis, and I'm the supervisor of the Client Services Department here at Cornerstone, your agency's billing partner. Thanks for joining us today. Typically, the documentation workshop is about 2 hours in length, but we've put together an abbreviated version to fit within your Con Ed day today. A little bit about me. I've been an EMT for over 11 years. And I was an EMS full-time as a provider and a director of operations at an EMS agency in York County until I joined the Cornerstone team in 2019. I'm still an active provider today, and I work on a part-time basis on a BLS unit at an EMS agency in Cumberland County. So I know and I understand what you face daily as an EMS provider, and I want to thank you for your service to your community. Today we'll explore the art of writing a patient care report, or a PCR, as good and proper documentation is directly tied to receiving the most reimbursement for your EMS agency for each and every call. Over the years, reimbursement from insurance companies, Medicare, Medicaid, has not increased in proportion with the expenses related to operating the EMS agency. So good documentation is now more important than ever as it relates to reimbursement. If you have any questions as we move through the workshop, please be sure to get those questions to your leadership team, and they'll get them over to me. We'll provide an answer as soon as we can. And with that, I'll share my screen so you can move through the workshop with me, and we'll get started. So this is a guide to improve EMS documentation. We provide this complimentary to our EMS agencies that we partner with as their billing company. Class objectives, we'll discuss and understand why EMS is under scrutiny, understand the role of a PCR, we'll understand the differences in levels of service, understand how documentation is interpreted, understand the fundamentals of good documentation and the pitfalls of inadequate documentation, and identify simple techniques for quality achievement. So a disclaimer, all materials is educational only. We're not an attorney or we're not a law firm. Nothing presented herein is intended to serve as legal advice. The unauthorized reproduction or distribution of this class and its materials is forbidden. So why EMS is under scrutiny? Now more than ever, documentation is being examined by payers using trained healthcare professionals. Since 2007, over $3.82 billion has been recovered through audits and investigations. EMS is just a small fraction of that, but even a small fraction of such a large number like $3.82 billion means big dollars, and the government is after every penny. So the role of a PCR, we'll talk about the medical and the QA record part of the PCR, or the aspect of the PCR, legal compliance document. It's the basis for reimbursement. It's also the source of data collection for those agencies such as Medicare. So there's differences in levels of service, as you know. Levels and types of service are emergency versus non-emergency, BLS versus ALS. We have just the ALS assessment rule, which we'll talk about that, ALS level 2, and then the SCT, or the specialty care transport. So emergencies, it requires an immediate response to a 911 or equivalent call. It's an immediate response is one in which the ambulance begins as quickly as possible to take the steps necessary to respond to the call. Regardless of the medium by which the call is made, the call is of an emergent nature based on the information available to the 911 center at the time the call was made to 911. And it's reasonable for the dispatcher to issue the emergency dispatch in light of accepted standard dispatch protocol. The use of lights and sirens, by the way, is not a determining factor of whether a transport can be billed as an emergency. Then we have non-emergency, which is any transport that does not meet the definition of an emergency. Can be scheduled or unscheduled. There's provisions for repetitive transports, There's an emphasis on medical necessity and an emphasis on supporting paperwork. The ALS assessment role, Advanced Life Support Assessment, is an assessment performed by an ALS crew or ALS provider as part of an emergency response that was necessary because of the patient's reported condition at the time of dispatch. And it was such that only an ALS crew was qualified to perform the assessment. An ALS assessment does not necessarily result in determination that the patient requires an ALS level of service. And then we have ALS level 2, and that corresponds with at least 3 separate administrations of 1 or more medications by intravenous push or bolus or by continuous infusion, or there's some bullet points here that qualify for ALS level 2. Ground ambulance transport and the provision of at least one of the procedures listed below. And you can see those outlined there. Manual defibrillation or cardioversion, endotracheal intubation, a central line, cardiac pacing, chest decompression, surgical airway, or an IO. And then we have specialty care transport, or SCT. That's an interfacility transportation of a critically ill or injured patient by ground ambulance and the provision of medically necessary supplies and service at a level beyond the scope of a paramedic. This is necessary when a patient's condition requires ongoing care by 1 or more health professionals in an appropriate specialty area, such as nursing, emergency medicine, respiratory care, cardiovascular care, or a paramedic with additional training. So this would be a special interfacility transport where a patient needs to be monitored by a respiratory therapist, for instance, or an emergency room physician, so forth. So we'll talk a little bit about how documentation is interpreted and how it relates to the ICD-10 codes that we use to bill calls. So there's a 10th revision of the International Statistical Classification of Diseases and Related Health Problems. It's administered by the World Health Organization. Documentation is translated into these codes, placed on the claim forms, and submitted for payment. And we'll dig into this a little bit in detail, but we won't focus on the codes. That's our job. But to put things in context, it helps to see the way it works. Each character adds a layer of detail, something we'll touch on momentarily with a few examples, such as this. So the code for toxic effect of unspecified snake venom, accidental, unintentional, initial, or first encounter is T63.001A. Okay, so this is the code for an unspecified snake venom. However, the toxic effect of a specific to rattlesnake venom, same thing, accidental, first encounter, but this time we identified the snake as a rattlesnake. The code is now changed to T63.011A. So there's a one code for an unidentified snake, and there's a specific code for rattlesnake, for instance. Toxic effect of venom of black widow spider, accidental, first encounter, T63.311A. And then toxic effect of contact with venomous toad, assault, this is a real code, initial encounter, T63.823A. So it's important to notice that being specific in your PCR, as specific as you can, determines the code that we need to use in coding trips and billing them out to insurance. A couple other examples, and these are, we always like to pick some of the weird ones out because these are actual codes that we could use if we needed to, but sucked into a jet engine, subsequent encounter, which means, by the way, that this was not the first time this happened to this patient. You see the code there for that. Activities involving arts and handcrafts, bitten by pig, initial encounter, bizarre personal experience, and then of course there is a code for problems with in-laws. So we'll talk about the fundamentals of a PCR and break it out into different sections: demographics, times, odometer, and narrative. And we'll get into these sections in more detail. We'll talk about the drill down details. So, using terms like left, right, bilateral, is it, instead of just saying the patient, had a broken arm. Well, was it left or right arm? Was it both arms, for instance? Using terms like proximal, distal, medial, lateral, anterior, posterior, inferior. These are all terms that are good to use in your PCR, because remember, health professionals are reading these PCRs at the payer, whether it be a commercial payer or Medicare, Medicaid. There's actual health professionals that are employed by these payers to review PCRs and documentation. We need to talk about the cause of the origin of a disease or abnormal condition that required the EMS transport. Think about accidents and traumas. What happened, what caused it, why is the patient being transported, mechanism of injury, nature of illness. It's important to capture the chief complaint versus reported complaint, as these help to reveal the proper etiology. We know that we often get dispatched for one thing, but the patient's actually experiencing something else that caused the 911 call. The severity, we want a quantitative 0 to 10 scale that we use for pain. Is it sharp, dull, stabbing? Is it aching? Is it crushing? These are all words to use in your PCR based on what the patient is telling you. Is it a mild, moderate, severe case? Does the pain radiate anywhere? Referred pain can point to an underlying issue. Are fractures open, closed, displaced, non-displaced? Capturing when the incident started. Capturing relevant details such as, is it intermittent? Is it reoccurring? Is it acute? Is it chronic? If they're having a breathing problem, is it chronic due to a COPD, or is this an acute respiratory issue? Post-op, post-delivery, or if they have an abdominal pain, but they had some sort of surgery a week prior, so is it post-operative? Post-delivery, for example, Z39.0 is the code for encounter for care and examination of mother immediately after delivery. Okay, so again, are you caring for a new mother who just delivered, or did she deliver a baby 2 weeks ago or a month ago? Our coders must determine if an incident is initial, subsequent, or sequela. For non-emergencies in particular, it's important to describe the original incident or issue affecting the current transport. Subsequent, which is after active phase of treatment, when a patient is receiving routine care during a period of recovery. Sequela is used to reflect complications or conditions that arise as a direct result of an injury, such as a scar or burn. So the logic of writing, how you tell the story of the call. There's similar concepts to SOAP or chart, but it's basically we are telling a story when we write the PCR for a transport. We want to capture the dispatch and response section of the PCR. Was it 911 equivalent? If it's non-emergency, explain the circumstances. Explain why the patient is being transported from facility A to facility B, and make that case as to why the patient had to go by ambulance. The nature of the call. Explain if it was an emergency or non-emergency. I'll go back to response. I skipped over that. Was the response immediate? Were you dispatched by your your county 911 center? Was your response immediate? And then, of course, explain if it's an emergency or non-emergency. Some counties have, classes, class 1, 2, 3, Alpha, Bravo, Charlie, those types of classes that can determine what level of call we're running. The chief complaint, so the patient's condition as described during dispatch, and if it's a non-emergency, precisely explain the reason for transport. Again, making that case as to why the patient had to be transported by ambulance versus a wheelchair van or car. Talk about your units. Is it a BLS unit? Is it a MICU? A paramedic EMT situation? Is it an ALS squad or an ALS chase truck? Always, list your unit numbers on your PCR, and make sure you notate any assisting units, which is often a paramedic for paramedic intercepts. Your arrival and assessment. Okay, so explain what you find when you arrive on scene. Where was the patient located? Were they in their living room? Were they in their bathroom on the second floor? Were they laying in bed? Were they in the backyard? Where were they located, and what you find, what the scene is like. Again, we're painting that picture. What's the situation at hand? Your initial observations, your general impression of the patient, their skin, eyes, breathing. Is the patient alert? Are they oriented? Are they answering questions appropriately? For non-emergencies, does the patient meet medical necessity for use of an ambulance? Report the complaint. What the patient or the family member tells you. What is the patient's complaint? Obviously, your assessment, a head-to-toe assessment. Use your mnemonics. Consider using OPQRST, ABPU, etc. Your treatment results. Treatment interventions, a thorough description of what you did. And we want to make sure that we're not putting something in our chart that we didn't do. We want to make sure we record everything that we did for that patient. So if you're using a template, for instance, for your narrative, it's good to make sure that you really go over that well before you close the chart or before you lock it. Because when we use templates, sometimes we leave things in there that we didn't necessarily do on this particular call. So make sure it's a thorough description of what you did. Results of treatment and interventions. What was the outcome of your treatment and your decisions? How did the patient respond to what you did? Packaging. Were they bandaged, boarded? Did you use C-spine stabilization? Did you use a long backboard? Did you use a C-collar? What straps did you use to secure them to the board or the stretcher? How did you get them to the ambulance? Did they walk? Did you have to assist them in walking? Did you use a stair chair? Did you use a Reeves litter? How did they get to the stretcher? Okay. Your transport and disposition. Transport and ongoing condition. So you want to talk about the patient's condition en route to the hospital. Your ongoing assessment, additional interventions. So we may do some things to treat the patient on scene, and then we get them in the ambulance, and we have transport time. And what did you do while you were en route to the hospital? And again, how did they respond to the treatment that you provided? Where are you taking the patient and why? Are you taking the patient to a trauma center because that's the protocol and it's the closest trauma center to where you're located or where the scene was? Or are you taking a patient to a certain facility because they've requested to go to that facility? When you get to the hospital, your transfer of care. How was the patient transferred? Were they sheet lifted? Were they log rolled? Did hospital workers assist? Which room did you go to, or bed number did you go to? So the final disposition, the patient's condition as transfer is completed. Again, was the patient better, worse, the same? Did your treatments help the patient? So we want to describe how the patient was at the time of transfer. And then we also will talk about refusals here. Document these the same extent as you would a transport. Be very thorough, explain what you said and did, what protocols you followed, if you talk to medical command. So it's all about the details, okay? The common thread to every example is this: when painting that picture, see if you can paint a masterpiece. Same concept applies to all scenarios, whether it's difficulty breathing, lacerations, punctures, avulsions, contusions, a cardiovascular accident, vomiting, pregnancy, fractures, burns, etc. The list goes on and on, but we want to document in detail every single call, no matter what it's for. So we talked about refusals really briefly a couple of seconds ago, but refusals and MVAs present a heightened risk of liability and potential lawsuits. So we have an emphasis on thorough documentation of refusals. Never assume that because there is no transport, there's no risk. And you want to follow your protocol. The goal is to ensure informed consent. Consent requires legal capacity, mental capacity, and knowledge of the situation. We want to assess for all three. Explain the risk of refusing care. Explain the benefits of proposed treatment, accepting care. Explain alternatives, options that may be available. Note, the threshold for asserting mental incapacity should be high. It's best to first assume a patient is capable of consenting to refusing care unless observations indicate otherwise. So for refusals, be sure to document your assessments and findings. Legal capacity, mental capacity, situational knowledge. Is the patient have their legal capacity to make the decision not to go to the hospital? Are they intoxicated? Are they under the influence of a substance? Do they have the mental capacity to make that decision? Document your discussions, interactions. What did you say? What did the patient say? What did the patient's family say? What's the patient's level of understanding? Document how you obtain the signed refusal form. Who signed the form? Did the patient sign the form? Did the patient's mother sign the form if the patient's a minor, for instance? If you consulted with medical command, make sure you document that. Most medical commanders will give you their medical command number when you call medical command. Record that medical command number on your PCR and on your refusal form. This is an example of a general refusal form, a typical refusal form that agencies use. Just like a PCR, you want to make sure you get all the patient's demographics, their name, their age, their date of birth, their phone number, the incident location. Make sure that you obviously get the patient's home address or mailing address if the incident location is not where they live. And that is in case we have to send them an invoice or any kind of billing documentation. Make sure you record all the vital signs, or a set of vital signs that you get. The shaded boxes, check marks in the shaded areas, it says require consult with medical command before patient releases. Okay, and of course we want signatures at the bottom, so a patient signature or a patient representative signature. Again, if the patient's a minor, it can be a parent, it can be grandparent. If the patient is of legal age, but for some reason can't sign, we have a representative sign there. And of course, you want to sign as the EMS provider as well. And it's important to note at the bottom right-hand corner, there's a witness signature. So, if the patient signs, you sign as the EMS provider. And if there's family on scene, a family member can sign as a witness. If there's no one else there except for the patient, your partner can sign as the witness. So we'll talk about some non-emergencies. Non-emergencies are the same as emergency trips. Documentation still needs to be completed. And oftentimes non-emergencies are scrutinized even more than emergency transports, especially by Medicare. So there's levels of service, obviously, for non-emergencies as well, BLS and ALS level 2, and SCTs, or specialty care transports. So there should be a call intake process at your agency for non-emergencies. As a best practice, we advise assuming a pre-authorization is always needed for every non-emergency transport. There should be a system designed to qualify and classify requests for transports prior to committing resources. and the need for pre-authorizations, not to be confused with the CMS prior authorization program, which is a separate system pertaining to repetitive transports. Pre-authorization, so depending on how a call intake system is designed, someone needs to contact the insurance the patient has to obtain a pre-auth. We need to validate the HCPCS codes, and there's a code for BLS transport, ALS transport, mileage. So we need to ensure proper mode of transport, and that may have changed since the pre-auth was obtained. We want to obtain identifying information of the insurance rep who either provided a pre-auth or said there was not a pre-auth needed. So if you're calling to get a pre-authorization from the patient's insurance prior to a non-emergency transport, and a representative at that insurance company says that there's no pre-auth needed, it's important to get the name of the insurance rep that you spoke with that told you there was no pre-auth needed. Consider using our sample call intake quick reference, which is on the next slide. That's just a call intake checklist. These are items that should be obtained prior to doing a non-emergency transport. So the CMS prior authorization program, it applies to ambulance suppliers. It does not apply to hospital-based providers. It's specific to repetitive patients, medically necessary, scheduled non-emergency transportation furnished 3 or more times during a 10-day period, or at least once per week for at least 3 straight weeks. Requires documentation be provided prior to claim submission, such as a physician certification statement, or a PCS, information on the clarifying physician, what is their NPI number, which is a national provider number that each physician has, and we need that information on the PCS. Number of transports being requested and the date range. And again, this is for getting a prior authorization from Medicare for repetitive transports. So we need to know the number of transports that's going to be requested, and pertinent documents from patient's medical records. Again, that explains why the patient will need all of these repetitive transports in a certain amount of time. Medicare issues an affirmed or non-affirmed decision. Both types of decisions result in a unique tracking number, or a UTN, that's attached to those transports. An affirmed decision can approve up to 40 round trips in a 60-day period. Transports exceeding this criteria require an additional prior authorization request. Claims can be submitted outside of this process, but they will automatically deny. But we do have appeal rights that we can appeal to Medicare for anything that denies. For hospice, a Medicare beneficiary may receive hospice benefits if he or she is terminally ill and must choose hospice election. Documentation plays a key role in enabling billing staff to determine if hospice is the appropriate payer. So again, it's important to specify on your PCR, is this patient being discharged from the hospital to home, and are they entering into hospice care? This information should be able to be obtained by the hospital or the discharging facility, and it should be included in the paperwork you get for the transport. Again, we need to determine if the patient is just now entering into hospice, or if they have already been enrolled in hospice, etc. Patients should be under hospice care, and the transport needs to be related to the hospice condition. So talking about some forms, the assignment of benefits, commonly referred to as a signature form. There's no official format that exists, but what follows is a widely used and Cornerstone preferred sample. This form addresses all key components. So this is a standard signature form, and we have 3 sections, which we'll talk about in more detail. So who signs section 1? The patient signs section 1 if the patient is unable to complete his or her name, but is able to make a mark in this section and the ambulance crew signs off as a witness at the time the mark was made, this would be considered valid. So section 1 is where the patient signs or makes their mark. If the patient's only able to make an X or make some kind of a mark on the patient line, there will need to be a witness, and that can be the ambulance crew. If a patient is suspected to have COVID-19, complete the following form. So it's the same form, but it was designed that if a patient is a suspected COVID-19 or confirmed COVID-19, and we don't want them having to sign a form, touching a pen, etc., this little box can be selected and completed here. Who signs in section 2? Well, if a patient is unable to sign due to being physically or mentally incapable, the provider needs to describe why this is, and then the authorized representative may sign. So authorized representatives include only the patient's legal guardian, relative, or other person who receives Social Security or other governmental benefits on behalf of the patient, a relative or other person who arranges the patient's treatment or exercise, other responsibility for the patient's affairs, or the representative of an agency or institution that did not furnish the services for which payment is claimed. So this section will be signed by the patient's legal guardian, i.e. mother, father, or parent, if the patient's a minor, or a relative or other person who receives Social Security or government benefits on the behalf of a patient. So a patient's husband, spouse, wife, if the patient can't sign. So we need their signature and date, and their printed name as well. And it's important that we use the top 2 lines there in this section to describe the circumstances that make it impractical for the patient to sign. It's important to note, and I've seen this happen several times, where a provider would write, the patient's unresponsive or unconscious or is not alert. However, in the PCR, it states that the patient walked to the ambulance and was answering questions. So, it's important that we fill these forms out and that they're accurate and true. And in section 3, the ambulance provider can sign, assuming it's the only option, which should be rare. It asserts that the patient is incapable to sign and no authorization or no authorized representative was available or willing to sign on behalf of the patient at the time of service. The provider completes all necessary fields and should have receiving facility representative sign, date, print name, and provide title. If no rep is available or willing to do this, a secondary form of verification from the receiving facility will suffice, such as a face sheet, skilled nursing facility administration or admin record, patient's medical record, hospital admission log, or other acceptable facility records. So if you need to get section 3 signed, the EMT or the ambulance provider can sign this and then also get a facility signature. If you absolutely cannot get someone from the facility to sign, as long as we have a face sheet or the skilled nursing facility administrative records, a patient medical record, that will suffice as well. Some medical necessity certification statement, MNCS, PMNC, CMM. There's a lot of acronyms for this form. It's can be for repetitive or non-repetitive. So repetitive is 3 or more times during a 10-day period, or at least once per week for at least 3 weeks. It must be obtained prior to service, and the MNCS must be assigned by the attending physician only and is valid for 60 days from the date signed. For non-repetitive transports, which is all other scenarios, should be obtained at the time of service. However, a 48-hour window is afforded after the services are furnished. Alternate claim filing methods are granted in cases when a completed MNCS cannot be obtained. MNCS may be signed by either the attending physician, physician assistant, nurse practitioner, clinical nurse specialist, registered nurse, licensed practical nurse, social worker, case manager, or discharge planner who is employed by the hospital or facility where the patient is being treated. This is a sample of medical necessity certification statement for non-emergency ambulance services. Okay, so there's three sections on here as well. All of the sections are very important, all the patient demographics at the top. And the second section is basically stating why the patient is being transported by ambulance. This is the medical necessity questionnaire. And then the section 3 is the signature of physician or other authorized healthcare professional. So medical necessity certification statements. It's a medical necessity questionnaire. It needs to state the patient's condition and accurately describe, and all applicable checkboxes are indicated. If bed confinement is notated, ensure all three criteria are met. Unable to get out of bed without assistance, unable to ambulate, unable to sit in a wheelchair or chair. So these are the three determining factors for bed confinement. And again, it's important that if the MNCS states that the patient is bed confined, however, they are able to walk to the stretcher, that is a determining factor whether or not Medicare may or may not pay the claim. So we want to get this form before the patient leaves the facility. We want to check to make sure the form is dated. An appropriate person has signed and indicated credentials. The signature and credentials are in the appropriate fields. The signature and credentials are legible. If not, the following may be considered acceptable. It's an illegible signature over a printed typed name. Okay, so if the signature is illegible but it's over top of a printed or typed name, that's fine. Illegible signature accompanied by signature log or attestation statement, or if we have the initials over a printed name. Electronic signatures are acceptable, but stamped signatures are not. We also have the Advanced Beneficiary Notice of Non-Coverage, commonly known as the ABN. This is given to a Medicare beneficiary when services furnished are believed to be partially or entirely not covered. It's mandatory in a limited number of scenarios, and we'll talk about them. It's optional in other situations. It's not permitted in emergency situations or when the patient is under duress. This is an example of an ABN form. So times when the ABN is mandatory. It helps to ask the following three questions. If all criteria are met, an ABN must be used. Is the service typically a covered ambulance benefit? Will payment for part or all of the service be denied because it is not reasonable and not necessary in particular instance? Is the patient stable and the transport non-emergent? So here are some scenarios when an ABN is mandatory. When a patient is transported for outpatient services which could have been more economically performed at the point of origin, meaning the patient's home, nursing home, or skilled nursing facility, for example, certain types of wound care, routine exam, blood draw, etc. When the level of care provided is air transport despite ground ambulance being covered mode of transport. Think of a beneficiary who requires non-emergency ground ambulance transportation from a local hospital to another hospital for a special procedure, yet the patient wants to be taken by air ambulance. In a case like this, the ground ambulance service is a covered benefit, but air transport is not reasonable and necessary for the patient's present condition. It's also mandatory when the level of care provided is ALS, though BLS would have been sufficient. When it's optional is non-medically necessary transports to a doctor's office or other non-covered destinations, wheelchair van or stretcher van transports, excess mileage, convenience transports. With excess mileage, though, I do want to point out that it's very good to notate if you know you have excess mileage, if you're going to a facility that's further away than a more local facility for a certain reason, it's important to note why on your PCR. Medicare specifically sometimes questions when you take a long distance transport and basically pass other facilities that could take the patient and provide the services. Scenarios when the ABN is not permitted, and this is obviously emergency situations when a patient may be under duress, so trauma situations, that kind of thing, or when the patient's under duress, it's not mandatory or permitted. Advance notice of non-covered services, commonly referred to as a Medicaid waiver. Some state Medicaid programs prohibit billing a Medicaid recipient for non-covered services unless the recipient or responsible party is informed before the service is rendered that he or she must pay for the services. In these cases, a recipient or responsible party must consent to receive the services and be responsible for payment. This is what a Medicaid advance notice of non-covered services look like. So some parting thoughts. Content. EMS documentation is a key component to the continuum of care. Other healthcare professionals can make important decisions that affect patient health based on the content of your PCR. There's a certain mindset. If you haven't already, we encourage you to adopt the mindset that a call is not complete until a thorough and appropriate detailed PCR is completed. The timing, complete your PCR as soon as time permits after the call. If your agency is lenient on this, take the initiative and set the standard for promptness. The quicker you complete your PCR, the better PCR you're going to write because the information is fresh in your mind, and the quicker we can get it as your billing company to get it processed. Professionalism, we encourage everyone to take the pride in their documentation. It reflects back on the provider, the agency, your partner, your crew, and their respective standards of professionalism. Thank you for attending today. Cornerstone is an employee-owned company with over 2 decades of experience in ambulance billing and revenue cycle management. You can visit us online at cornerstoneadministsystems.com. We do have a quick reference guide, a documentation quick reference guide available on our website. Make sure you follow us on the social medias. If you have any questions, again, have your leadership reach out to us with questions, and we'll be happy to get them to you as soon as possible.